Good morning, good afternoon, good evening, and good night, friends and colleagues from across the world. Thank you for joining us today on our first Podinar session of the weekend. And we have an exciting program for all of you with four very high-profile speakers, seasoned educators from across the world. And today we have Dr. Emad Salloum, which is a personal honor for me to introduce him and host him. Thank you so much for joining us, Doctor, from Syria.
Thank you, for hosting me. It's a great pleasure to be with you on Global Summit. Maybe it's the first time, but I'm sure that it wouldn't be the last.
Thanks so much, and I have you on a special day for me. It's my 40th birthday.
Yeah, I know.
Today.
Happy birthday, Keanu. Yeah, I know that. So
Thank
you
you
came
so
now
much.
40, huh? 40 is the critical age. Okay.
Yes, that's what I hear.
Now,
Not quite sure if I should be happy or sad or what the scenario is.
You should feel more happy, as I told you before, that each age you can enjoy every year in your age. It's the matter of how you feel in your heart. So don't worry, aging is not aging in the heart.
Thank you so much for those kind words, and I hope that it's a new beginning versus the other way in terms of things going downhill from here. I wanted to thank the thousands of happy birthday wishes and our colleagues that have come through from all the different platforms, be it LinkedIn, Instagram, Facebook, and on it goes. I really appreciate you guys. There should be no confusion that the dream team of doctors in the background working with us and myself are working for you, for doctors to have independence and autonomy over the profession, and we will continue to do so in the years to come. With that said, I would like to introduce our superstar of the day, who happens to address a very unique topic for us. He'll be speaking to us about managing risks and complications of anterior mandible oral surgeries. Most of us usually find comfort in anterior mandible because there is a lesser concern with nerves and blood vessels and so forth. But Dr. Emad will give us a awakening today about all the things that could go wrong up there. And let's take a look at Dr. Salloum's biography. For those of you guys that don't know him.
Can I be just for seconds off screen so I connect my charger while you complete your...
while I do your presentation? Absolutely, doctor. Please proceed.
Just 1 minute. Go ahead.
So Dr. Salloum graduated from dental school, Damascus University in 1981, where he completed his residency program at the Damascus General Hospital and became board certified in oral and maxillofacial surgery in 1986. He also attended an extern fellowship training at Emory University and Emory Clinic in Atlanta, USA, 1982, 1992, 1998. He's also a diplomate and ambassador of the International Congress of Oral Implantologists and ambassador of Digital Dentistry Society. In fact, the American Academy of Oral Surgery that we operate has recently partnered up with the Digital Dentistry Society, and many of us are also diplomates of the ICOI, so this is a great fit here. He's also a board member of the Syrian Association of Oral Maxillofacially and an elected editorial board member of the Syrian Association of Implant Dentistry. He's a speaker and director of advanced surgical implant courses for the British Academy of Implant and Restorative Dentistry, BARD. Had been a speaker, Baird, yes. That's with Paul Tipton, correct?
Yes, correct.
Yes. He had been a speaker and regional course supervisor for Dentsply Trident, Nuance Implants. He's also an international expert for Dental XP. Dr. Salloum had been lecturing in several regional and international conferences and published several posters and clinic studies. He's the chief surgeon and director of Salloum Dental Clinic and Training Center, Tartus in Syria. Wonderful, doctor. It's quite an honor to have you with us, and that you're taking your time to help us. In a green room for a minute, I was speaking to you about the American Academy of Oral Surgery, which had invited you to be a ambassador.
It's a great pleasure for me to be joining the American Academy of Oral Surgery as an ambassador. Actually, it's a great honor for me to be with you. Thank you for naming
very
me.
excited to have you. Let me get your opinion, doctor. What do you think about the silent epidemic of edentialism and all the oral surgery problems that we have? Our mission at the AOS is to educate and train all specialties and all general dentists and their staff in office-based oral surgery, the things that we can do and it's within our limitations, to reduce this epidemic. What do you think about this mission as an oral surgeon?
Well, in fact, as a surgeon, even that all the surgeons are really accused of being rough or tough or taking the surgery by means of surgery. But in fact, we don't forget that we are dentists. And the dentists, the main mission of a dentist is to keep the teeth in place, not to take them out. So even as we are surgeons, we need to be very conservative in our decisions. We should know when to do and when not to do. And during the your question is how to deal with the pandemic situation, you mean?
Yes.
Well,
there's a very big number. I think over 2.5 billion people are affected by either edentialism or missing, cavitated teeth or needle oral surgery treatments. And although oral surgeons have great intention, there's simply not enough oral surgeons to care for all these people.
Well, actually, it's not the same here in my area. We have a lot of oral surgeons. Yes, we have a lot of oral surgeons. During the total lockdown, most of the dentists, they closed their clinics. But oral surgeons, as they deal with the emergency cases and all the abscesses, all the infectious cases, even trauma, we kept working just as usual. So we held all the responsibility, sometimes even to be replacing the general dentists in how to deal with those patients. So our situation was very tough during the lockdown and during the peak of the pandemic. Now we are a little bit relaxed because the pandemic is now is on a lower rate. So we are able almost to work normally now in our clinics.
Lovely. So, Doc, you've been at it since the early 80s. You've seen a lot of things happen and come. I think you're going over 40 years now almost.
Yeah.
Is that correct?
Look at gray hair, okay? So
you look like you have a little bit more hair than I do. So you're doing something right. But you've seen a lot of things come. You have had some education in the United States. You're practicing over in Syria. What motivated you to do all the things that you have done for dentistry and oral surgery over a span of 4 decades?
I would summarize it just in one phrase. If the time goes to the past again, 40 years, 50 years behind, and you will let me choose what to do, I would just say, I will choose the same way I took. Because
you wouldn't change anything.
No, absolutely nothing.
That's great.
Absolutely nothing. Even my wife, okay?
How many years have you been married?
Now, I've been married now for 35 years.
Congratulations. That's wonderful. I got 11 and it's not...
and my wife, dentist also, she was my colleague. She was my classmate. So so we took all this road together. And as I told you, I love my career and dentistry and oral maxillofacial surgery is my passion, as well as teaching is one of my passions also. So I'll take the same road, even if I go back 40 years before.
That's wonderful. That's wonderful. So, Doc, tell us a little bit more about any memorable events in your dental career, that mistake that you might have made that other dentists could benefit from your learnings and experience. So you're saying you wouldn't have done anything in your entire life, but surely
Mm.
you've done some mistakes
A lot
clinically,
of
right?
mistakes. A lot of mistakes, man. A lot of mistakes. And
Tell us about a couple of them, the ones that could help our colleagues prevent
yeah,
doing the same in the future.
yeah, I would say it's one of the complications, which is actually it's a mistake. Uh, 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 by the way, I have a lecture, special presentation, which is called the cutting edge complications versus mistakes in immediate implantation. So we did during our practice lot of mistakes, unintentionally doing mistakes, because at that time it was the lack of knowledge. But one of my what I call mistakes, but I was able to manage. I was doing an implant for about a 65 years old lady, and I didn't take quite enough protection, and she had the cuff reflex, and the screwdriver slipped from my hand and went into the lung. So
Oh,
yes, it was
that can
into the lung.
happen. That can
Yeah,
happen to all of us, right?
yes, yes, and for a moment she was just shocking, and I was able, because I have a background for let's say general anesthesia and emergency medicine, so I was able to put her in the position that it went into the trachea inside and into the trachea of the right lung. So I took the patient to the hospital, and through endoscopy they took all the screwdriver out. Since then,
How'd you know it wasn't a lung? Did you take an
yeah,
X-ray or
yeah,
you
yeah,
took
yeah,
a...
yeah, sure. He took her to the hospital and took an X-ray, because I knew from the first moment that it's in the lung.
that it aspirated? Okay.
Yes,
So usually you send them in. The lung is an unfortunate situation when that
yeah,
happens. Now,
yeah,
what is your solution? Are you putting some floss on there, or are you
yes.
holding?
Just put a floss, so you can just grab it in case that the patient had a reflex of cough or vomiting or something, so you can grasp the or and even protect the lingual part with a small gauze. So if you put a small gauze here, you will protect your screwdriver from slipping.
Excellent. Yeah, so it's those little learnings that we that can prevent us a really, really bad day
Yeah.
at a dental office, and we promote our colleagues from informing us of these kind of things. You know, you mentioned something about when to extract and not to extract. I see one of the doctors here is also involved with the American Academy of Oral Surgery. He's an endodontist, and that's what he teaches is
Oh,
is when to know to extract and when not to extract.
that's true.
So I agree with you. That's a very good position to have in a multidisciplinary approach. That we want to save everything we can, and then when it's no longer a savable situation, it becomes a post-extraction type
Absolutely.
scenario.
Yes. Because
So tell
we
me,
have to remember that our main mission is to keep the teeth, not to
correct?
extract them
Yes,
and place implants.
yes. Some people are, they're set in their ways where they do full arches and zap the bone down and put implants in and take out
Over
good teeth.
exaggerated cases, actually. I find a
Yes,
lot of cases that I see on Facebook or Instagram, and sometimes I put a comment, what was the indication for extraction? Most of those teeth, in let's
that
say
is
70, 80% of the cases, they are restorable teeth, and they shouldn't be taken out and doing bone reduction and then placing implants.
excellent. Yes, I agree with you. Over exaggerated cases. And what you don't see on Facebook a lot are complications management. A lot of people are posting beautiful cases, and not just Facebook and all of the platforms.
Yeah.
But people are afraid of the response if they post bad cases. But in reality, we learn from those bad cases. Um, So what? Tell me about the anterior mandible. This is usually our safe zone. We go there to harvest bone. We place implants deep as we want.
Sure,
What's
sure.
going on up there? What happens? Are you talking
Well,
about the
actually,
anatomy and like unusual anatomy, site nerves, site, or what is it about?
no, it's like a sublingual hemorrhage that could happen, and it could be up to reach a fatal condition.
Yes,
Yeah.
yes.
And the story of my presentation actually started when one of my best colleagues, and he's one of the master oral maxillofacial surgeons in the Middle East, and he had a complication while he was doing a simple genioplasty under local anesthesia. And this is one of the things that I don't do it in local. But he was so experienced, and he was doing a simple genioplasty for a young man. And after 2 hours, they called him from the hospital, and this young man was suffocating a lot, and unfortunately, he passed away. So, and he passed away because of the total airway obstruction due to this severe hematoma in the sublingual space. So, this complication is extremely rare,
Yes.
but it's extremely fatal, and it comes and the progress comes in 2 hours. So that's why I'll be focusing on this complication, because if you know this complication, you are always able to avoid it.
I agree. This is great. Actually, I remember that there's a lot going on in the submandibular space too that people should be very, very worried about,
Yeah.
with two different arteries passing through there. But let's me go ahead and wrap up the introduction here. Now, we would love to start listening to this lecture, myself and all of the others that are tuning in. With that said, Dr. Salloum, I'm going to go ahead and bring up the presentation, and the floor is yours. Let me go down here. Yes, you may commence.
Okay. Can you still see my screen?
Yes, perfect.
Okay. At the beginning, thank you so much for hosting me. It's a great pleasure to be with you all and with all the audience. I say hello to you all from Syria, my beautiful place, and I would love that everybody would have the chance to come and visit us when the pandemic is over and when the situation comes to an end in my area. Well, uh, I would really love to be with you on podium and see you in person. But the total lockdown of this entire world due to the COVID-19 crisis made us so far away. So we are together always from behind this screen. I wish shortly this will be all over and we are able to meet in person. I will share with you today my topic about managing risks and complications in anterior mandibular implant therapy. I will focus because most of you, as a general dentists, the most oral surgical cases that you do, maybe you are doing extractions or simple extractions or surgical extraction, but most of you, they are doing implants. And this complication is totally related to this implant. I will try to stuck with the verse that Winston Churchill says that the speech or any kind of speech or presentation is like a woman's skirt. It should be long enough to cover the subject and short enough to create some interest. So I'll try to stick with this with his advice and start right away. As we all know, and you all know, that the anterior
Sorry,
mandible.
Doc. I got to
Yeah,
notice. Sorry to cut you off. I got to notice that the screen is blue on the live version. Could you please check the presentation and see if it's playing?
can you see it now?
Checking on the live version. Hang on 1 second, please. Good, 1 second. We want to make sure that they can see your screen. Not yet, Doc.
It says on my computer, it says that I am sharing this screen. So do I?
Let me see if we can get our... If you'd like to close it out and select the entire screen.
You think so? Okay.
Yeah, select the entire screen, please. See if that will bring it in.
So I'll close this and go back again to share my screen, right?
Yes, let's try that.
Okay.
Stop sharing the existing screen and share your entire screen.
Stop. I stopped. But now your entire screen, okay. I'm trying to. Can you see my screen now or no?
Not yet. It hasn't come into the stream, no.
Oh my God. Okay, wait. Let me. Can you see it now?
Yes.
The presentation. So you see the presentation?
Yes, I can. Let me see. Hang on 1 second. There we go. Okay.
Done?
Yes, hang on 1 second. Let's make sure it's also live. It's working. And then we should be set, Doc. Little glitch in the system. Unsure, is it live?
Yeah, it's there.
Perfect. Sorry about the interruption, doctor.
Don't worry. So I make it now as a full screen and play it, right?
Okay. Yes, you should be able to.
Sorry, dear colleagues, for this kind of interruption. So I'll start right away, not to lose time. As you all know, that the anterior mandible, or to be more precise, the interforaminal area, had been advocated as the site of choice for implant placement because it has the best bone quality. Even in the atrophied mandibles, it has the highest success rate of implants. And this area, the interforaminal area, is suitable for all kind of prosthetic work, regardless if it's removable or fixed detachable or even the full fixed bridge. As you see, we can do all kind of prosthetic work just by placing implants between the two foramens. That's why it's considered a safe surgical area and the ideal area for the new implantologists to start to placing implants, because this area is far from important and vital anatomical structures. Unfortunately, since 2001, a case report by Joseph Nimatsu had been said that it was a near fatal airway obstruction after just routine implant placement in the canine area. This case came to the hospital with a severe hemorrhage, severe edema in the sublingual space, with a very swollen tongue, and a almost total airway obstruction, and the patient was admitted to the hospital in a near fatal condition. Timothy Isaacson said that it was a rapidly progressing elevation of the floor of the mouth with sublingual hematoma, and the swelling appeared to have crossed the midline. Two publications. This severe edema and this severe hematoma, because all the blood had been collected or gathered in the tissues of the floor of the mouth, because those tissues are lax, and the hemorrhage result in diffuse hematoma than a discrete collection which would be easily to drain. So it will be a diffuse hematoma in the sublingual space that will raise the tongue in a way that it will obstruct the nasopharynx and the oropharynx. Al-Bustani and his co-workers also published his report case where the sublingual hematoma formation after implant placement is an uncommon complication, but it's potentially life-threatening. And this complication is most likely to happen in severe cases with bone atrophy in the mandible, or in cases where they're used increased length of dental implants. Manzikos and his co-workers also published his paper in 2007, where he suffered the same complication. He faced the same complication while doing minor oral surgery for removing a torus mandibularis case. That was in 2007. Reviewing the literature, there are not so many cases that had been published. I will show you later now. It's about, until 2008, not more than 16 to 18 cases had been published through the literature. Even there are not so many cases, very few, but those cases were enough to trigger the alarm bell for reviewing our understanding of the anatomy. We have to go for a review of what we know of the anatomy in the floor of the mouth. Of course, we all studied in our dental school a long time ago that according to many anatomy textbooks, the blood supply to the mandibular lingual gingiva and the floor of the mouth is derived from the sublingual branch of the lingual artery. And what Bavitz and Holmes have found, even in 1994, that the sublingual artery was found to be a little bit small or insignificant in 53 of the cases, with sometimes a variation exists in which that there is the submental branch of the facial artery, which perforates the mylohyoid muscle. This will give the blood supply to the region combined with the sublingual artery. Those findings that had been suggested by Holmes and Bavitz that time and published in 1997, those findings would suggest the need for a new refinement of our approach for the extraoral ligation procedure, which means, according to their recommendations, any bleeding in the sublingual area, we should ligate first the facial artery, and then, if necessary, we ligate the lingual artery. So the priority now is to the submental artery, which is a small branch from the facial artery that pierces the mylohyoid muscle and appears in the floor of the mouth. Hofschneider, in his study, which was published in 1999, also stated the same result, that assesses the vascular supply to this region. There is a contribution and importance of the sublingual artery versus the submental artery. So he made like a comparison, and he found that the sublingual artery was found only in 71 of the specimens, while the submental artery, which is perforating the mylohyoid muscle, was found in 41% of the cases at about 30 millimeter posterior to the menton area. I will show you later now where is this artery. As we all see now on the screen, this is the common facial artery, and this is the submental artery. In 40% of the cases, it stays in the submental area, while in 60% of the cases, it pierces and perforates the mylohyoid muscle and goes directly in this space to the floor of the mouth area. And you will see now how it will be diffused in this area. In a study made by Anis Flanjan in 2003, about the important artery supply of the mandible and how to control an arterial hemorrhage after those kinds of incidents. He stated that the lingual artery and the hypoglossal nerves were more inferior than classically described. So usually the lingual artery goes in an inferior position than we used to know, while the submental artery, it goes directly in the floor of the mouth and can be considered as the main blood supply for the floor of the mouth and the mandibular lingual gingiva. After it distributes from the facial artery, it goes right away up to the floor of the mouth, not so far from the lingual part of the mandible. And this is drawing for it, how it perforates the mylohyoid muscle and approaches even to the most anterior area of the mandible. In other studies, like the one made by Kalpidis in 2004, he stated that there is also a kind of anastomosis between the lingual artery and the submental artery. And both of them, they may enter the lingual part of the mandible through a foramen, which is called the lingual foramen. And this lingual foramen, we didn't know anything about it before. We just discovered that after the discovery and the CT scan photos. Mardinger and his co-workers in 2007, in his study, he said that this submental artery just lies in a very close distance of the lingual part of the mandible. It's only 2 millimeters away from the lingual part of the mandible in the canine area. As you see here, it's not far more than 2 millimeter and maybe 4 millimeter in the mental and the second molar area. So it's a very close artery to the lingual part of the mandible. So any injury to the lingual plate, you may accidentally injure this artery. And you will be all surprised that the diameter of this dissected vessel or this submental artery could be from 0.5 millimeter up to 3 millimeter maximum. So the mean value of the diameter of this artery is 1.5 millimeter. And a 1.5 millimeter is a big artery to be considered through our management of bleeding. Reviewing all the literature and all the clinical research and all the journals, the peer journals that have been
You have some technical issues with the internet, I believe, and Dr. Emad will be back soon, hopefully. But meanwhile, we will go ahead and take a little break and continue the session as soon as we have Dr. Emad back. Thank you so much for your patience, and we'll return shortly. While we have the audience here, maybe I can briefly discuss the upcoming Global Summits project. It's the American Academy of Oral Surgery 2020 Global Summit. It'll be our 4th Global Summit this year. We have a very exciting program planned for all of our friends and colleagues from across the world. It should be known that the American Academy of Oral Surgery caters to all dentists, all specialists, and all staff members who wish to further their education in office-based oral surgery, which is a very broad topic. Most dental appointments are driven by pain, and they end up in offices where a root canal or an open med or an oral surgery procedure may be necessary. And it's prudent that our colleagues have the skills to do this with competence and have a common resource to turn to get the education and training and information that they need. And also we are establishing a community for doctors under the American Academy of Oral Surgery. But the exciting event that's coming up is that we are going to have 30+ world-renowned speakers. We have our ambassadors in our regions that are going to be participating. We have a virtual exhibition hall for the first time, where due to the COVID-19 going on still, we thought it was safer this year to conduct this event virtually. And you will be able to roam the virtual exhibit hall and actually have live interactions with live representatives from those entities and products and services, where we'll also do interviews about interesting products coming up pertaining to dentistry and various specialties that are applicable in this scenario. And then last but not least, we have a virtual award ceremony coming up where we will honor the tremendous number of doctors from the Global Summit, as well as the speakers of the AOS. And with that said, also you have a bonus CE that's coming up. The bonus CE will entail your requirements can be met, vast majority of state requirements in terms of infection control, having 2 hours there with the COVID precautions, and then HIPAA and OSHA, some very important topics that I used to go to the CDA and get it. They're not there right now to do it. They're gonna risk, they're going also virtual, and then the greater New York, and a lot of events are going virtual. So some of our colleagues might be asking where they're going to get their license requirements done. Come and get it done with us. It's complimentary and it's a bonus, and we would love to have you. And also plus this bonus comes a wide array of essentially a toolbox in oral surgery with all these topics in there that you can benefit from. There'll be 2 tracks. You're welcome to go to the courses that you take the most interest in, and earn 16 CE units while you do it, and also meet your license requirements. One last thing is AA-OS existing members will receive 50% off the registration fee, which is a nominal fee of $98. And as a perk, they receive half of the registration fee waived, and they can participate in that capacity. So any dentist, so there's no confusion, any general dentist, any dental specialist from any specialty, including pedodontics, periodontics, prosthodontics, endodontics, orthodontics, is welcome at the AOFOS. And we have a very exciting program coming up. I hope you guys will join us. This will be a robust meeting, November 21 to 22. We hope to have you all there. We will take a little break to correct the technical issues. I believe there's an internet connection problem at this time. So we will return for the second part of this podinar. Thank you so much for your patience and for being part of our a vast organization that stretches across the world. We look forward to servicing you and continue to bringing complementary education to our colleagues on the Podinar platform across the world by some of the most seasoned, well-known, respected speakers. Thank you so much, and we will be back very shortly.